So first we're going to discuss heme synthesis. So heme and hemoglobin is probably one of the most important concepts that you will carry with you throughout your medical career. Whether you're an internist, whether you're a surgeon, whether you're in the operating room, the wards, the SICU, whatever it may be, this concept will really never stray too far from your understanding of how the body works. So first, heme synthesis starts off with what we call heme. Heme is an iron-containing organic compound that is found within hemoglobin. That is the protein. And the primary function of this is just to carry oxygen throughout the body to help perfuse all the organs. Heme is a cyclic-shaped structure with fused rings that has an iron compound right dead smack in the middle. So here is the overview of the heme synthesis pathway and the interplay between the mitochondria and the cytosol and other respective enzymes. What I would encourage you as I go through the next slides is to kind of keep your textbook with you open so you can reference this image. So heme synthesis all starts with the concept of what a porphyrin is. So porphyrin is a portion of heme, that structure that surrounds that iron that we just talked about. So porphyrinogens are porphyrin precursors that form the porphyrin by linking pyrrole rings that then will bind to the iron. They will bind to the iron at the center of the structure. And this is important because if you remember from your chemistry days, whenever you have a cyclic structure, compound structure, this interplay between these structures will actually cause absorption of ultraviolet light. And what happens is because you can absorb UV light with these structures, they can become irritated, and they can also become increased higher energy capacities, which then cause irritation to the surrounding skin. So it's essentially, it's almost like these absorb light, they heat up, and they can cause damage to the skin and surrounding structures. And that's often why all these processes that occur with heme, or these deficits that occur, you also get a lot of dermatitis that's associated with it because of these rings. These rings absorb the light, and they can cause irritation of the skin. So heme synthesis is a series of enzymatic reactions that all start with glycine, succinyl-CoA, and B6 as cofactor. So the first enzyme in all this, the rate-limiting step that you really need to know and really need to commit to memory, is aminolevulinic acid synthase, or D-ALA. And if you can memorize that, you're pretty much in a good place because a lot of these are very difficult to memorize, but this is often one that's very tested upon. So D-ALA is often the very one tested because it's a rate-limiting step. So the initial substrate produced during the synthesis of this heme is D-ALA, which is first produced inside the mitochondria. So once ALA is produced, it is then shuttled to the cytoplasm for further processing. So enzyme synthesis returns to the mitochondria where the enzyme ferroketolase catalyzes the final step of adding the iron to it. The final step involves the protoporphyrin receiving iron to make the heme, which is the final substance. If an enzymatic step in the heme synthesis is disrupted for any reason, and you'll have an accumulation of these heme precursors, an accumulation of these cyclic structures, and what you do is you get these porphyrias that often have what I said before, these dermatitis or these skin sensitivities. What's very, very important to know and to remember is that glucose and heme both act as negative feedback on the mechanisms that produce it. So if you have increase in glucose or increase in heme, it'll actually shut this system down. So now we're going to talk about hemoglobin. So now that we kind of understand what heme is all about, and if you have any trouble, feel free to go back and look over the enzymes that are respectively important for heme synthesis. But here we're going to talk about hemoglobin. So hemoglobin is a protein that has 4 polypeptide subunits within it. It has 2 alphas, it has 2 betas, and because of this, each of these can bind to oxygen, which is very important in understanding how cooperativity works. So, what is cooperativity? If you remember, we talked about a little bit in enzyme kinematics, but cooperativity is when oxygen binds to one of the 4 heme groups and induces a conformational change that then increases the probability that oxygen will then bind to the subsequent chains of the hemoglobin. And on the flip side, when one oxygen molecule leaves, it increases the probability that it will release oxygen from the other 3 chains as well. And so for every time an oxygen molecule, say it leaves the alpha 1 chain here first, it increases the probability that oxygen will then subsequently leave alpha chain 2, and beta chain 2, beta chain 2. So you have to understand that whatever way it's going to increase the probability that the next one is either going to attach to hemoglobin or be released from hemoglobin. So since hemoglobin is tetrameric, it allows hemoglobin to increase its oxygen carrying capacity and deliver oxygen when bound to any of the subunit hemoglobin. And we discussed before, myoglobin is very similar to kind of what hemoglobin is, but it does not have the ability to do this because it is monomeric. So it does not have the cooperativity capabilities. So what happens is if you were to do a Michaelis-Menten curve, this is cooperativity, that is hemoglobin, that's myoglobin. Cooperativity, no cooperativity. And this is the reason why myoglobin is such a poor oxygen delivering mechanism, because it doesn't have the ability to carry as much oxygen needed to keep the organs perfused that hemoglobin can do. So hemoglobin really does take on two forms, as we described before, because if you're having oxygen leave it, it's all going to leave. All is going to go away. If you have oxygen binding, then it all is going to bind. So what happens is you have this interplay between a taut form and a relaxed form. So the taut conformation, the taut form of hemoglobin demonstrates a deoxygenated or low affinity for it. So I think of it being taut, very tight, that doesn't really want to bind to oxygen, and relaxed means like it's okay, it's easy going, and oxygen can easily bind to it. And that's how I kind of remember it, because it's hard to kind of figure out which one wants oxygen to bind to hemoglobin. So you just got to remember it. Taut, low affinity. Relaxed is high affinity. So when we talk about hemoglobin, we can't go by without explaining kind of the hemoglobin percent saturation in the presence of PO2 and how it kind of shifts the curve, the oxygen saturation curve. So certain factors can either increase or decrease the affinity of oxygen binding to hemoglobin. And this is very important when we're talking about things like sepsis or temperature or hypothermia or biochemical processes that can influence the environment. It's going to change how oxygen binds to hemoglobin. So for example, you can have substances like chloride or acidity or a glycolytic byproduct, 2,3-BPG, or carbon dioxide, temperature. They all favor the taut form. So what happens, remember what the taut form is? Taut form is the tight form that doesn't bind to oxygen so well. So if you're in this form, it creates a state in which the hemoglobin is more likely to release the oxygen. So all of these factors cause a shift to the right on the hemoglobin curve. So if you shift to the right, that means the binding affinity goes down. If you shift to the left, the binding affinity gets even tighter. It's stronger. Oxygen does not want to leave. So when I think of it, I always think like on the left side of here is your oxygen saturation curve, and over here it's very close to oxygen. And because it's very close to oxygen, the shifting to the left means that it has a higher binding affinity. And that's just kind of how I remember it, because sometimes I would get confused. So a decrease in any of these above values that we just described above will cause it to shift in the opposite direction. And you really, really, truly need to memorize all of these, because it's not just important for a test, but it's honestly really important when your attending gives you an ABG and tells you, explain to me these findings. And you have to explain to them the findings in the setting of the oxygen saturation. It can be tough. So here's what we kind of described, and this is kind of a very good image of it. So as you can see, you have the Haldane effect and the Bohr effect. Haldane effect, essentially, when you boil it down, it occurs when oxygen displaces carbon dioxide. That's honestly, it can be very confusing, but just remember that. Haldane is represented as when oxygen displaces CO2. Because CO2, when you make it in your body, travels back to the lungs via three ways. It can be traveled through just being carbon dioxide. It can just be carbon dioxide in the blood. It can bind to hemoglobin, or it also can just become bicarbonate. And those are the three ways that you can transport carbon dioxide back to the lungs. And you really need to memorize that, because that helps you understand the Haldane effect. This is where oxygen displaces CO2, and Haldane really occurs in the lungs. Bohr occurs out in the periphery. And this is where you have increased CO2, decreases the pH, which then causes decreased binding affinity of oxygen to the hemoglobin, which is what you want when you're in the periphery, because you want that oxygen to then be released into the tissue for perfusion. Now that oxygen has been released from hemoglobin, now the carbon dioxide can now bind to the hemoglobin. And that's what the Bohr effect really explains and really talks about. So I'm going to explain it one more time. So when you have carbon dioxide in the body, carbon dioxide in excess will decrease the pH. It makes this environment more acidic. Okay? So when you decrease the pH, it forces oxygen to be released from hemoglobin. When it's released from hemoglobin, it allows the carbon dioxide to now bind to the hemoglobin, and it also allows for oxygen to be released, again, to help perfuse that tissue. And that's what Bohr effect is really explaining. It's explaining the interplay between oxygen and carbon dioxide to help with both tissue perfusion and also helping with transporting of the carbon dioxide back towards the lungs. Another really important concept that we're going to discuss here is what the fetal hemoglobin is all about. So fetal hemoglobin is important because the baby needs oxygen just like the adult or the mother to survive. The problem is if the baby has, let's say this is the mother right here, this is the mother's hemoglobin. If this was also the baby's, right, say these lines are almost negligible, they overlap each other, there's no reason why oxygen will be in the blood, the hemoglobin in the placenta, and then it's going to willingly choose the hemoglobin in the baby if it has the exact same binding affinity. And if that was the case and they had the exact same binding affinity, then the baby's going to be hypoperfused and it's not going to have the ability to sustain an oxygen capacity needed to survive. So that's why the body created a fetal hemoglobin like this. It's shifted to the left. Oxygen is more tightly bound to the fetal hemoglobin. So say this is the placenta, and then this is the fetus, and this is the mother. What happens now, see the blood vessels go in, come out, and then the fetus goes in, comes back out. So when blood from the mother has oxygen binding to hemoglobin on an adult hemoglobin chain, it passes through the placenta. As it passes through the placenta, the fetal hemoglobin has a tighter binding affinity to oxygen. So what happens is now this oxygen will then shift and bind to the hemoglobin of the fetus and is carried through. So yeah, in terms of the most optimal means of perfusing tissue, is fetal hemoglobin the best? No, of course not. That's why we don't have it in an adult. But in terms of trying to steal oxygen away from the mother, this is a great way to do that. And this is a great way for the body to do that. So the fetal hemoglobin has a tighter binding affinity to oxygen so that it can steal oxygen from the mother's adult hemoglobin and use to perfuse the baby's tissues. So now I'm going to talk about some clinical pearls. So these are very high yield. So heme synthesis can be very daunting because a lot of these words are very difficult to even pronounce, let alone understand. But if you understand what these clinical pearls are, you can really do a very good job of understanding how these are tested clinically. And also, if you understand the Bohr and Howland effect, then you're in a really good place. So lead poisoning. So lead is very important because this will disrupt the heme synthesis by affecting ferroketolase enzyme, ALA dehydratase, which then leads to the accumulation of protoporphyrin and D-ALA. And then this can cause toxic effects. You can get lead lines in the bones. You can get discoloration, an oral, intraoral discoloration. And it can often present with microcytic anemia, GI distress, which is so common. These people come in, and it's a very confused picture because they can have kidney disease, and then they have very, very strong or very, very painful abdominal pain out of proportion to what you may be thinking going on. You may be thinking small bowel obstruction, appendicitis, but it's just always a very confusing picture as to why do these people have such GI distress. And if you're having a GI distress in the setting of a very unusual picture, please always think of lead poisoning, always, because it's oftentimes something that can rear its ugly head. So when younger children and infants are exposed to lead poisoning, this is really profound. It's very sad, but it can cause very permanent, lifelong neurologic and cognitive defects and deterioration that's irreparable. And that's honestly what's been happening oftentimes in these cities in the Midwest. As you're getting in like Flint, Michigan, where they have lead poisoning in the local water, and these kids are having neurological deficits from it because it causes demyelination of the nerve sheaths, which can cause permanent destruction of the nerve itself. So now we're going to talk about the porphyria. So these are very important, especially when we're talking about the heme synthesis. So acute intermittent porphyria, or AIP, this occurs when porphobilinogen deaminase is disrupted and creates an accumulation of porphobilinogen, D-ALA, and corphobilinogen. And again, these are all tough because they're hard to pronounce, but you really do need to memorize what is accumulated when you have this disease process. And then you have to understand the classical signs or symptoms. So you get port wine colored urine, you get abdominal pain, like I said before, with lead poisoning, you get abdominal pain, but then you really get the polyneuropathy and the psychological manifestations. So these are all very important presentations. But right here, this is absolutely money right here. So certain drugs, like including alcohol and cytochrome P450s, such as phenobarbital, can actually induce this. They can actually induce this from happening, and this is often tested upon. So a lot of times you're classically given the picture: port wine colored urine, abdominal pain, polyneuropathy, and they'll maybe even give you the acute intermittent porphyria, and they'll ask you, what drug may they be on, or what drug may they have taken. And you need to know, probably this one mostly, are cytochrome P450 inducers. Also, you need to know that in order to reduce the effects of these accumulated precursors, patients are treated with glucose and heme in order to inhibit synthase activity. And if you remember back to that heme synthesis, that these can cause a negative feedback on the ALA system, and that's why you need to memorize that as well. So porphyria cutaneous tarda is often difficult to remember between AIP, but the way I remembered it is this has cutania, and that's how I remember this is going to have like those blistering skin dermatitis manifestations because of those cyclic rings. And I also like to have the fact that they see in it for cutania because this is the most common porphyria. So when in doubt, if you have a confusing picture and they're not giving you the blistering skin, you could almost maybe get away with it being the most common, so thinking PCT. But again, you're gonna have to try to figure out based on the clinical presentation. So again, like I said, the heme precursors will accumulate in the skin itself, and because you have these cyclic rings will then absorb the light, absorb the UV light, and cause kind of increased energy output that will irritate the skin. The next one is congenital erythropoietic porphyria, or Gunther disease. This is an AR disease, and you got to remember, I know it's annoying, but you just have to memorize its inheritance patterns. This is AR. It's a mutation in uroporphyrin 3 synthase. The precursor levels, you have an increased level of uroporphyrin, corpoporphyrin in the urine and feces. Most likely you're going to have it that is in a larger concentration in the urine greater than the feces. And you're going to have elevated uroporphyrin, corpoporphyrin, protoporphyrin in the red blood cells, this is how you differentiate it from the other ones, from AIP and cutaneous tarda as well. So ultimately, you're also going to see elevated uroporphyrin and corpoporphyrin in the plasma, but this is how you're going to figure out that this is different from the other ones right here, this box right here. And this is probably the most important aspect that you're going to have to memorize within this disease. But like I said, AIP and cutaneous tarda, these are the ones that are probably the most tested on. And I remember I told you those hallmarks that you need to figure out and memorize within those respective diseases. And that concludes this chapter of Da Vinci Academy.